Good afternoon. My name is Dallas Raybig, and I am the Infant and Early Childhood Mental Health State Coordinator for Alabama, and I will be speaking today on the role of higher education in supporting the infant and early childhood mental health system of care. So we know that infant and early childhood mental health is the developing capacity of the child from birth to 5 years of age to form close and secure adult and peer relationships, to experience and manage and express a full range of emotions, and to explore the environment and learn, all within the context of the family, the community, and culture. And when we talk about infant and early childhood mental health, we are referring to a child's social and emotional development that is interconnected with the holistic health and overall well-being of the developing child. And for young children, social emotional development is influenced by all of the adults and the community members in their lives. And therefore, infant and early childhood mental health is enacted within multiple settings and sectors and systems designed to support the young child and their families. And that includes health care, early care and education, early intervention, child welfare, and many, many more. And so this transdisciplinary nature of infant and early childhood mental health really creates a significant layer of complexity. And so the provision of mental health services doesn't really live within one system, but it involves a broad network of systems of care that provide a continuum of social emotional supports. So in Alabama, our system of care, our vision is that every child has the opportunity from the very beginning to reach their full potential within healthy, positive relationships. And our mission is to create and sustain a culturally sensitive system that promotes positive early experiences through collaborative partnerships, empowering families, and building capacity across communities. So when we talk about developing an infant and early childhood mental health professional development system or a workforce capacity, building our workforce capacity, we really had to think about the model for developing a workforce system. And so we initially began just a few years ago by surveying mental health providers, licensed mental health providers throughout the state to kind of find out what is it that they know about infant and early childhood mental health. Do they know, are they aware of training opportunities? Are they aware of endorsement processes through our First Five Alabama, which is our infant and early childhood mental health association, professional association? Do they have they become aware of training opportunities such as the DC 0 to 5, FAN, child parent psychotherapy? What models, what modalities have our mental health providers been trained to provide services through? And what we found was, and we kind of hypothesized that this was the case, but what we found was that very few clinicians knew anything about providing mental health services under the age of 5. And I think we had one response that had some idea of what to do for birth to 3. And so we got to work thinking about what we needed. And so to do that, we had to think about what systems were in place to support any type of policy changes that would need to happen. And then we had to think about the gaps, not just the gap in services for mental health providers, but what is the gap with early care and education professionals? What's the gap in our healthcare system with pediatricians? And then we had to develop those strategies. And going back to that yellow bubble where it says forecast needs, we had to forecast needs 1 year, 2 years, 3 years, 4 years, 5 years out. But we also had to think about, if we were able to make these things happen in these short baby steps, these small baby steps, what were going to be the needs 10 years down the road. And so we began putting things in place. We applied for grants. We got really involved with 0 to 3. And we were accepted into their policy technical assistance program that they do. And so we were really excited. They really did help us develop strategies. We got involved with Georgetown through doing technical assistance with them as well. And so we've really been able to nail down some of those strategies. Well, then we had to implement those strategies. And to implement strategies, you have to have funds, you have to have funding. And so we're constantly writing for grants. But something very interesting here in our state is that we have strong state agency relationships. And so we decided, we can't depend on grants. They're not always going to be there. And that money isn't money that lasts forever, right? It runs out eventually. So we really started leveraging relationships, our state partner relationships, as well as our community partner relationships. And what we found is that our partners were willing to share. They were willing to share funding. They were willing to share time. They were willing to help us do this work. And so the work that we're doing around infant and early childhood mental health isn't from one single agency. We have partners, we have university partners, which we'll talk about today. We have the Department of Mental Health, the Department of Early Childhood Education, the Department of Human Resources, the University of Alabama, the University of Alabama at Birmingham, Children's Hospital at the University of Alabama at Birmingham, the Auburn University. So we have Alabama Partnership for Children. I can't forget them. So we have all of these partners, and we've decided to put together a leadership team where we, from all of members from all of the different systems and the different air partners, so that we could come together on every other week, and we talk about where we are in our strategy and our plan, and what do we need to do next? What are our barriers? Have we identified any more gaps that we need to address? And so leveraging those relationships has been probably the single most important factor in us being able to do the work that we're doing. So as we define our gaps and we think about strategies, we're going to focus primarily on mental health versus early care and education and healthcare for this particular presentation. So some of the key questions that we wanted to answer is where is the infant early childhood mental health workforce located? And what resources are currently available to the Alabama workforce? What gaps exist in awareness and access to these resources? And how can the system be strengthened? And what we found is, and I'm going to add the early care and education workforce here because one of our strongest partners is between the Alabama Department of Early Childhood Education and the Alabama Department of Mental Health. And my role is split between the two. So I coordinate efforts between those two agencies in regards to workforce development funding for projects and initiatives, and to work on policy changes. So what we've found is that in the early care and education workforce, our teachers and caregivers were feeling undersupported and overwhelmed with challenging behaviors and really feeling like they didn't have the capacity and knowledge and skill to address the mental health issues that they were seeing, and especially after COVID. We found that early care and education used a patchwork of strategies throughout the state, either provided by mental health consultants, coaches, or other resources. And there was also a lack of foundational knowledge in typical and atypical development, most especially brain development. And after COVID, when early care settings were really struggling to staff their agencies, their child care agencies, we also noticed that the average age of a child care provider was getting younger and younger and younger. And so there's a lack of experience in caring for children by children themselves, really. And so we really needed to address the typical versus atypical childhood development. And then toxic stress and trauma sensitive care and self care. It's really amazing that you think about self care with yourself, and then when you ask another professional, what are you doing for self care? And there's suddenly this aha moment that, oh wow, I have not been taking care of myself. Well, let's talk about that. Let's have this reflective conversation around self-care and what you have available to you, and how you can promote and advocate for your own self-care. And then in the mental health workforce, we found a lack of foundational knowledge in early childhood development and infant and early childhood mental health theoretical foundations, and then assessment and diagnosis of infants and toddlers. And that has been a really fun area to explore with clinical mental health providers around assessment and diagnosis and the theoretical foundations. Because we've also found that our clinical mental health providers have a lot of those theoretical foundations that they didn't realize were applicable to the birth to 5 population. So that has been a lot of fun generating the interest around the professional development opportunities around those foundations. And then we found that there was a lack of access to workforce development opportunities and training programs that solely focus on infant and early childhood mental health. So as we decided, well, we have this funding. Let's get CPP, child parent psychotherapy here. Let's get the infant mental health foundations here. Let's get FAN, facilitating attuned interactions, mothers and babies, all of these wonderful things that, we had the funding to provide, but yet we weren't getting a lot of participants. And what we found, part of the reason was funding, and then letting people know, hey, this is being funded from a grant. You're not going to have to pay for it. So come on, let's fill these seats. And really generating that interest and understanding that we have that available. And then the other lack of access to institutions of higher ed in providing continuing education. There's only one. We'll talk about Troy University here momentarily, but there's a barrier, a financial barrier for students or licensed clinicians to be able to go back to school and take a specialized study track in infant and early childhood mental health. So we went on the search for ways in which we could develop that piece. So identifying the gaps really depends on awareness. You know, we have to identify those gaps, but also making sure that the workforce is aware of what's available, aware of where to get the funding to attend professional development opportunities or to attend an institution of higher learning to complete a specialized learning track. And then there's access, having access to those particular pieces, and especially in our rural areas, and really focusing on, you know, the diversity of the workforce and who was coming to our training opportunities. And we did notice that the majority of the people attending any of our workforce development events were white and female. And so we made a concerted and a collaborative effort to really reach out into the community mental health settings and into the rural areas, making sure that we're messaging, making sure that everyone is aware that these opportunities exist and that we will do whatever we can to make that accessible to you. Equitable access. One of the programs in particular, training programs, is child parent psychotherapy. And our goal was to, or is, to make sure that all 67 counties in our state have access to a CPP provider by 2025. This is 2023, and we have 32 providers either that have completed the training, are completing the training, and working on their rostering. So we're on our way to having those 67 providers, one for each county. Excuse me. While there may not be one in each county, they're accessible to the community mental health centers that serve multiple counties. And then there's the application of the work. We encourage our participants to not just attend the training. In fact, for most of our trainings, we seek a commitment from the participants that they will apply what they've learned to their practices. Case in point, for FAN training, facilitating attuned interactions, when we work with an agency who wants to send a group from their agency through the training, we go through a readiness checklist with them. Is your administration ready to support the training, which is 18 months, 12 months? 8 months. Is your administration ready to provide supervision for these people for these participants once the training is over with, once the mentoring is over with? Are they willing to allow the participants to go through both levels 1 and 2 training and participate in that mentorship? For child parent psychotherapy, we ask for agencies to sponsor participants, not necessarily financially, but their sponsorship includes supporting reflective supervision for the clinicians, allowing them the time to attend the intensive trainings that take place, and allowing them time in their schedule to receive the reflective supervision and the case consultation calls that are required in order to become rostered. A couple of times we've had agencies back out right at the beginning when they realize the intensity of the training, but have rejoined in subsequent cohorts once they felt like they had the internal system in place to support the clinicians to do it. So our intent is to make sure that we're not just frivolously offering trainings for anybody to attend. Of course, anybody can. Our intent is that there's a commitment behind you attending these trainings, because that's the only way that it is truly sustainable in the field, within community organizations. So some of our key findings you'll see here is it looks like a house. So some of the things that we had in place with our partnerships, or our partnership between the Department of Mental Health and Early Childhood Education, we developed a strong mental health consultation piece with a network of around 25 mental health consultants across the state that serve early intervention, substance use disorder, special women's programs, our state-funded first-class pre-K, early care and education, and our early Head Start child care partnership. But in order for that to reach a level of strength that it needed to, there needed to be a foundation within our mental health workforce, and that's the piece that we have really been working on the most in the last couple of years. And when we talk about sustainability and being able to make sure that this will keep going beyond any funding sources that we receive that are grants, we knew that we needed to form an alliance with institutions of higher ed. And we needed to be educating our mental health workforce from the very beginning. So within their counseling programs or their social work programs. And as we thought through that, we thought, well, wouldn't it be great if early childhood educators in their master's programs, they could get some infant and early childhood mental health foundational knowledge as well. And then, what about our future pediatricians, and what about other human service programs? And so we reached out to several universities, and we kept running into hiccups and challenges to making this work. And when we reached out to Troy University, they just happened to have had all the pieces in place and they were ready to go. And I was really curious, or we were really curious, why did Troy have all the pieces in place? How did they have all the pieces in place that we needed? And what exactly were those pieces? And as we sat down with them to really go through, how do we know that you are committed to helping us make this thing work with developing this infant early childhood mental health graduate certificate program? We came up with several questions. And so we were able to create a readiness checklist. And I'm going to show you guys that readiness checklist here in just a few moments. But we were able to really look through what were some additional questions that we needed to identify and answer with this new partner. But through this partner, we've been able to bring a specialized postgraduate certificate program to Alabama that is solely focused on infant and early childhood mental health. And it's a 12-month program, and it includes a field training piece and an internship piece. And with that, we have been able to recruit from the participants of the certificate program into our child parent psychotherapy learning collaboratives, which has allowed that to grow. But we've also been able to recruit for the Troy program through the child parent psychotherapy Learning Collaborative. And then through all of our partners across systems and disciplines, we have been able to recruit across uh, all of these systems to provide, to make folks aware that we have these trainings available and opportunities available, and we can make them accessible to you regardless of your financial situation. The Troy certificate is completely online, except for the first, at the very beginning, you meet in person, and then at the very end, you meet in person. So it's asynchronous, and all of the coursework, except for those 2 dates, are done completely online. Your reflective supervision that you receive throughout the entire program is completely online. And so, there's, I guess, the only barrier would be a lack of access to the internet. And if that's the case and somebody really wants to attend this program, we'll find a way. We can find a way for you. So it's been a very interesting journey with Troy University. And our first cohort, we had about 18. I think in our second cohort, no, 16 in the first cohort, 18 in the second cohort, and our third cohort will have 30 seats available. And so far, we've had 40 applicants. And so we're really excited to see the growth and the interest of this particular program. Oh, so here are the questions, and I don't know how well you can see this in there because it kind of looks kind of small to me. But so these are some of the questions that we realized that other institutions of higher ed might need to consider before starting a program such as the Infant and Early Childhood Mental Health Certificate program. And so we wanted to make sure that they could identify expert faculty members in the curriculum design, which we were able to do. And then identifying faculty members who work well as a team together and who can work well with an outside agency such as a state agency. So my state agency was the funder for this particular program. And so we wanted to make sure that we could work well together, meeting the needs of the grant while also meeting the needs of the university as well. And identifying faculty members that have time to commit to the design, the implementation, and the maintenance of the program. We were very fortunate that Dr. Patrick Faircloth, who was our lead, our Troy University lead at the time, had earlier in his career was an infant and early childhood mental health provider, and he trained under some of the most notable theorists out there at the time. He's since retired, but he was very instrumental in us being able to get this off the ground. And then, someone who can commit to shepherding the program. My co-presenter who wasn't able to be here today is Dr. Samantha Booker, and she is our shepherd for the program and helping us to sustain it and keep it going. And then our chair, Dr. Sherionda Crawford at Troy University, has offered support all along the way and includes DECE every year when we review the course, the materials, the curriculum, and we make whatever adjustments need to be made. They always include us in those conversations. So those are just some of the items that are listed on this questionnaire or this readiness checklist. And so if anyone would like to see the actual checklist, because this one looks like the numbers did not come across as they're supposed to, but if you are interested, you can email me at the Alabama Department of Early Childhood Education, and I'll be more than happy to share that with you. All right, so our graduate certificate, the requirements for it right now are a master's degree in counseling, social work, nursing, early childhood education, or other human service. Their graduate degree program needed to have required a field experience and a commitment to serve the birth defy population for 1 year post certificate, because right now all seats are scholarship. It is unique in that it is multidisciplinary. So we have early childhood educators, counselors, mental health counselors who are in training or who have come back to complete this particular program, social workers. I believe we had this year, for the first time, we had 3 students to take it as an elective who are not even in a human service program. They wanted to see what it was all about. And one of those students has uh, reached out to change their major. They now want to serve this age population and they want to do it in a human service field. And I think that's pretty awesome. Not to take away from engineers and educators or anybody else, but I think it's just pretty profound that a 12-month certificate program can have that much impact on a person and their career choice. It is immersive and reflective supervision. So our students receive reflective supervision for the entire time. And when they've completed the program, they are eligible to begin the application process to become endorsed through First Five Alabama in infant or early childhood uh, mental health, whether that's a family associate or in the family services categories. And then for our coursework, they get an intro to infant and early childhood mental health, theoretical foundations. They learn about testing and evaluation, assessment, and diagnosis. They get the full DC 0 to 5 training. So they don't just get introduced to the DC 0 to 5, they get the DC 0 to 5 training. And often, as I mentioned previously, they hear about CPP, they hear about PCIT, they hear about all of these infant and early childhood mental health modalities, and often they will request to be allowed to participate in some of those cohorts. So again, we have a lot of back and forth from um, this program to CPP and to FAN training. And what's really interesting is that we've allowed some of our mental health consultants to go through this certificate program, and they've come out just with an unbelievable sense of competency as mental health consultants. And so now we're really thinking about, do we want to send all mental health consultants as they are new hires through this certificate program and allow that to be part of their onboarding and training for the first year? And part of that is that that agency that the consultant is associated with would also commit to funding their seat in the course once the scholarships run out, if we run out of scholarship money. And then they have an internship, and they do infant caregiver observations for the duration of the program as well. So some of our lessons learned, real quick. So in year 1 is when we developed the readiness plan for institutions of higher ed to support this type of programming. And this is something that is phenomenal about Troy. They're willing to share this. And because they are so committed to seeing the expansion of this work throughout the state, they're not all about owning it. And they're willing to share the lessons learned and the resource tools that are being developed as they go through these 3 years of implementation. the intensity of the program from the perspective of non-counseling students, while it prepared students to have a more full conceptualization of child development from a mental health lens, it was very intense. And so we took the feedback and we came to the table and we were like, okay, so everybody's saying, even our clinicians are saying this is really intense. So how can we pare it down without watering it down? And so we made some adjustments, and of course we planned for our sustainability. That is a plan for sustainability, because if people don't want to come, it can't be sustained, right? So we took all of that feedback and we made adjustments. And in year two, we wanted to think about, what does field experience mean to different scopes of practice? Are we making sure that if we make this a multidisciplinary program, do all of those disciplines have the opportunity to have a field experience that matches up to their scope of practice? So that was a discussion that we had. And then our recruitment efforts, again, the students that took it as an elective, that was just a very interesting thing. We thought, yeah, let's try it. They didn't take the whole program. They just took one course. So I have to correct myself on that. They took one course, and there was one student that said, I want to do the whole thing. I'm ready. I need to know this. And that's pretty awesome that we can sell people like that. And then there were challenges with reflective supervision along the way. And so we made sure this year that all of the faculty for this particular program went through the Reflective Supervision Learning Collaborative through the Alliance for the Advancement of Infant Mental Health. And so they are getting ready to finish up their 12-month intensive on providing reflective supervision, because we want our students to really experience reflective supervision in all of its beauty and all of its space and all of the wonderful things that reflective supervision has to offer us in this field. And then again, plans for sustainability. Now we're marketing. Now we're beginning to really message this program and what we're doing. So some of our qualitative insights, that consistently students are reporting how well the birth to five knowledge fits in with being a clinician and giving insight to their adult clients, no matter what phase of life that they're in. And they're able to see their clients as a whole person, with those childhood experiences factored into why they are in counseling to begin with. And then our non-clinical students are just amazed at how differently they look at children and families now as educators, as coaches, and then how differently they look at their teachers now. And having experienced that reflective supervision for 12 months, and how they are now able to hold those teachers in that reflective space in these challenging situations in the classroom. So our projections for year three, again, we have 30 available seats and 40 applicants, and we are so excited about that. And so this really does message that that the perceived value of this program, that now our scholarships are competitive. We have to really look at those applicants and try to find 30, not find them, but try to pick 30 out of those 40 participants who are ready to jump in with both feet. And then the diversity of applicants, the goal of reaching at a minimum that 60-40 ratio rule, for lack of a better word. But this just tells us, it lets us know how well we're doing at outreach. And you'll see in just a few minutes how the diversity of the first two cohorts has grown. And this has a lot to do with our outreach efforts and recruiting efforts. And again, messaging to community mental health agencies through the Alabama Department of Mental Health. They've started blasting the program when we're ready to accept applications. They're blasting it to all of the certified community mental health centers that they're partners with and that they fund, and to the substance use disorder agencies as well. So, we're looking. We want everyone to have the opportunity, or to at least be aware that this opportunity is available. And so what we know from formative and summative assessments over time, that if we have that accountability in place and we hold to that accountability, and we take into consideration the assessments, the evaluations, and we refine the program year after year to make it better and better, that we can achieve those objectives of training a multidisciplinary group of professionals across the state to truly make impact on the lives of children and families across the state. So here, as promised, is cohort 1 of the certificate program. So this is actually the cohort and some of the instructors. This is cohort 2. So you see it's gotten a little bit bigger, and we're a little more diverse in our group. And I can't wait to see the picture that will come in July for cohort 3. And I'm really excited about that. And that is it in a nutshell, the things that we're doing. So you can see that it is really important that we partner with institutions of higher ed, because we have to start at the bottom, not at the bottom, but we have to think about our pool of professionals, our future professionals, and how do we recruit them into mental health, and how do we recruit them into infant and early childhood mental health. And that is it.
Thank you so much, Dallas. That was really, really incredible. And as a former resident of Alabama, that is where I'm from, it is really exciting to see this work. And I know that we do have some questions in the chat. I'm going to see if Kiki wants to come up on stage.
Okay, here's one. Oh, on stage? There's a stage?
You're on stage. We are on stage right now. The virtual stage.
Okay, so what sort of testing and evaluation tools is the training on? So the students are trained in the TOVA. They're trained in the DC 0 to 5 for diagnosis, and they receive training on the use of the Piccolo. And let's see what else. I'm trying to think what else. And some of the more common assessment tools or screening tools, such as strengths and difficulties questionnaire, things like that. But there's gosh, I wish I had my syllabus in front of me to list off all of the screenings and assessments that they are trained on.
And I just brought Kiki back up on the stage. If you want to ask your second question too, Kiki.
Let's see. Can you hear me?
Yeah.
Kiki, I knew I recognized your name. Oh my goodness. Look, your little y'all's stuff is sitting here. My notes right here. Yes, we love Washington.
You know I'm going to ask you those questions, huh?
Yeah.
Well, I cannot figure out how to turn on my video, but you can hear me, so that's all right. And I think you know what I look like, anyways, Dallas. Anyone else? I'll send you a picture of me. But thank you so much for your answers to the questions about the different tools. And in Washington, we have free DC 0 to 5 training, which is great. But folks often say, that's great that I know the diagnoses, but how do I get the skills to actually, look at behaviors and look at parent-child interaction, and what tools should I use, and how should I do observation? So thank you so much for listing out these 3 that I'll share back with our team.
And well, it's interesting because we've gotten some of the same feedback, not from the participants in the Troy program, because they get trained in how to do the observations. They're doing observations throughout the program for the 12 months, and they practice using different tools to do that with. So, but they stay with the same family, so they're watching the relationship. So they're really honing in on how to observe relationships. And so, but what you asked actually was a feedback question when we did the DC 0 to 5 training as a pre-con for our state counseling association. We got the same questions. So actually, I am in the process of sending a proposal to do a session on assessment to go along with the DC 0 to 5 pre-con for this next year. And our mental health consultants have also, we're doing like once a year, we do like this spring retreat training thing. I wish they wouldn't call it a retreat because they're really training.
Like a retreat from what?
I know, right? But we do all of our assessment and screening trainings during the spring when school has just let out. And we actually have a university partner that has a child care center / pre-K that is also a teaching. So they
like
have
a lab
those
school.
rooms. Yeah, they have the hidden rooms, the two-way windows. And so our consultants will get to sit in there and observe and at least practice doing screenings that way. We also have a pre-K program locally here in Montgomery that we use as a field training site. And so the consultants get to practice using their swivels, so their cameras when they're doing consultation, but they also get to practice having reflective conversations with the teacher, and they get to practice using their screening tools there in the classroom with the students and the parents. So that we're hoping that piece is going to grow. That this is our first year doing that, so we've had a few hiccups. So we'll see how that goes.
Amazing, thank you. And I might follow up with you offline just to check in.
Oh yeah, we need to follow up with you guys. I mean, no kidding. And I never did even mention about Medicaid, how we have, we are getting ready to, hopefully, fingers crossed, and the creek don't rise, have a new chapter in our Medicaid billing policy dedicated solely to infant and early childhood mental health.
Ooh,
So that's
that's
going to really help us create a nice billing pathway for everyone who's doing that type of work. So, and
do you want me to ask my other question now, or do you want the other person to go, Catherine, to go next?
Well, the competitive thing piece.
Yeah, just like if you end up getting more applicants than spots, will there be preference for clinical folks, or will you try to maintain some sort of mix of backgrounds? If you know the answer.
Right. The goal is to maintain a mix of backgrounds and as much diversity as we can accomplish in the program. Absolutely. No. So the CANS assessment tool for Catherine Powell, if I'm not mistaken, if that's the same CANS that all states use, maybe it is. I don't know. It's been a while since I've looked at the CANS to see how closely related it is to the Strengths and Difficulties questionnaire. But I know that the SDQ comes from the perspective of the teacher and the parent. I think the CANS does as well, except for the adolescent one. I think the adolescents get to answer their own questions. I'm not sure. look. But yeah, I haven't looked at the cans in a while. Because we looked at that initially when we were looking at assessments to use. Because I know a lot of our community mental health centers use the cans.
And I don't want to jump in where I'm not needed, but in Washington, we also use the cans in some of the mental health centers. And how I think about the difference between something like the SDQ and the cans is more of a tool to help people figure out where needs are and how to address those. It can be pretty high level. And you would use something like the SDQ as like your measurement tool kind of to understand, okay, specifically for behavioral or developmental concerns, where are things, how do we evaluate that on like a psychometric level as opposed to like a sociometric level?
Yes, absolutely. That's a great comparison there, Kiki. The SDQ being a subjective, how do I feel um, about my child, where the other one is what are the needs, or the sociometric. Yeah, it is sociometric.
In Washington, our early childhood cans for each section that's about developmental or emotional or behavioral needs, we crosswalk it to the applicable section of the DC 0 to 5.
Oh, really?
So if people are, working in tandem with the clinician who did the diagnosis or before the diagnosis, they can have some synergy between doing that cans and the DC 0 to 5. They don't have to, but if they want to speak both languages, that's in there for them. I think I can get a link to it and put it in the chat. I'll check right now.
Yeah, that would be awesome, Kiki. I hadn't even thought about that. Any other questions? Well, I see. Look, I've had my chat turned to a different window. I'm going to put my contact information on here.
And I apologize. I was just talking on mute for like a good minute or so.
Oh, yay!
Yeah, we love that. So I did just bring Catherine to the stage. I don't know if you wanted to say anything else, Catherine, about the cans conversation.
Thanks, Karina.
Oh, and I see you're in Q&A. Yeah, you wanna speak, Catherine? Go ahead.
Oh, I was just going to say thank you, Kiki and Dallas, for that clarifications. It makes sense, the differentiation of those. So that was really helpful. Thank you.
You're welcome. Kiki, I think I have your email address.
And before any of the rest of the audience leaves, I do want to ask that you go to the top of the chat. You should see that little blue bar and fill out the survey for this session. Please, 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 before you take off. And then our closing will start at the top of the hour, so a little over 30 minutes we have, and you can poke around the platform, go into the tables, networking, or go eat some lunch or whatever.
So let me say this really quick. There were some people asking for slides. I did not get my slides turned in time for them to be uploaded here. There were branding issues. So I have them. If anyone would like a copy of the slides, I dropped my email in the chat, and feel free to email me and I'll send them to you. And there is a question about the ASQ from Teresa Hargrave. And yes, the ASQ is completed through Help Me Grow. All of our first class pre-K classrooms do the ASQ on every student in first class pre-K. And our mental health consultants, some of them are can do ASQs on children in early care. And I think the ASQ was completed in Head Start and Early Head Start programs here. So that's it.
All right. Thank you so much, Dallas.
Well, thank you guys, and everybody have a wonderful rest of your day.
All right.
And I guess,
Thank you.
do I just like
I'll press in the session. Thank you.